Telling Kobe, Emma, I am not going to have class on Wednesday. I'm leaving for vacation, so I will not have class on Wednesday. We're going to go out to Cool Deadwood Nights for a couple of days and hang out. So after class tonight, I will send you the study guide for the test for Monday. And then we can get together like Sunday night at 8 o'clock again, anybody who wants to, join in to review for the test or whatever. So my portion of the test is all done and is all ready. So I think my study guide should walk you through all the things that I felt that were very important over those sections that we did. So tonight we're going to talk about fluids and electrolytes in acid-base balances. And so this is really opening up the door to the meat and potatoes of what we do. There'll be a lot more systems-orientated stuff from here on out. I think we have a couple more delegation and odd and end things to cover, but most of them will be systems-orientated and from here on out. So when we talk about fluids and electrolytes, I think the important thing is to remember with every system that we talk about, our body's job is to maintain homeostasis, to keep us at equilibrium and balance at all times. And that's what our job does. And that's what every organ of the body tries to maintain at all times. So no different with fluids and electrolytes. So by maintaining balance and stability, it monitors the fluids and the electrolytes of our body. It looks at the nutrients, the enzymes, the hormones, and then also waste removal. Our body fluids, intracellular, so the fluid inside of our cells, is about 40% of the body's fluid. It contains potassium, magnesium, and phosphate. Extracellular fluid, this is the interstitial fluid, the fluid that's between each of the cells, and then also this the fluid that's within the vascular system is the extracellular fluid. So when we're looking at maintaining homeostasis and maintaining balance, there's different organs or different neurotransmitters within the body that help maintain that. And the first one is in the brain, and that's in the hypothalamus. It monitors through the antidiuretic hormone or the brain antidiuretic hormone. So we will talk about BNP later on, and that's what monitors this neurotransmitter or this hormone that monitors how much fluid is in the body. So we'll talk about BNP later on when we talk about congestive heart failure and those kinds of things, because the BNP is that transmitter that monitors that fluid over status. And so we'll monitor the BNP when we get to the CHF. So the brain or the hypothalamus monitors fluid balance. The kidneys monitor it through the adrenal glands and the renin, angiotensin, and aldosterone system. I'm not going into a depth about that system at this point in time because we will talk about that very much in depth when we get to the renal section of our lectures. It's a great big theory, and it's very, very overwhelming. So we'll talk about it then and not so much right now. And then our heart also monitors, and that's in the atrial natropeptic peptide, or the AMP. So those three places are what monitors the fluid status of our body. It determines whether our body needs to save fluid or whether our body needs to excrete fluid. And so either the kidneys will reabsorb fluid, or otherwise they will excrete them. And it's all based upon the adrenal glands and the peptides in the brain and in the heart that monitor that and tell the kidneys whether that it needs to excrete or whether it needs to save and conserve. Intake and output. If you look at table 42-2, that's in that Perry Potter book. It talks about intake and output. So basically, the normal intake of an adult should be about 2,500 mils a day. 1,200 of that is going to be from fluid, and 1,000 of that is going to be from food. And that's what our normal intake should be. Now, the Perry Potter book has a little bit different numbers. 2,500 is about the normal. They say 1,100 to 1,400 for food or for fluids, and 800 to 1,000 for food. So the numbers are pretty much the same, but there's a little bit of difference of that, just a small amount. And then the normal output should be about 2,000 mils per day. And Perry Potter says 22 to 2,700, so kind of in that ballpark. And so urovolemic, if we are truly urovolemic, how much fluid goes in should be how much fluid comes back out. And that's when we know that the body has come back to homeostasis, that we've achieved that homeostasis balance. So if you think about it, if somebody is sick in the hospital, we're monitoring how much they go in and how much they pee out, right? We're monitoring, we're keeping eyes and O's all the time. And so we really want to get that number to be balanced as possible, because then that really means that the body has kind of gone back to normal or to that urovolemic state. So reasons for intake and output, things that can go wrong, overhydration or dehydration. And so with overhydration, we see that there's an excess fluid in the interstitial tissues, localized versus systemic. So we're talking about, do they have localized edema or do they have systemic edema? Localized edema is our our pitting edema, when we're looking at feet and pushing in and measuring how much pitting edema a person has. Whereas systemic edema is called anascara, and that's just generalized systemic edema. Working in long-term healthcare, you guys have probably seen this, at the end of life, those kinds of things, when people are just from head to toe, they have fluid overload, or they are just edematous from head to toe, and that's called anascara. Third spacing is when in between the skin and the cells, that fluid begins to accumulate in between those levels of skin, and that's when they begin to start third spacing. So have you seen anybody with kidney disease who has ascites?
Is that when their skin?
Well, that's jaundice. When their skin turns yellow, that's a jaundice. Ascites is when they have those great big pot bellies.
Oh, yeah.
Have you seen that? Yep, that's third spacing. So that's when that fluid is beginning to build up between the cells of the body and the skin of the body, and that's called third spacing. And ascites is excess peritoneal fluid, and that's when they'll tap those people just for comfort. It always comes back once you get ascites. You can never get rid of it. You will always have it, but we will do paracentesis and thoracentesis just for comfort's sake, because it makes people breathe better and it makes people have less abdominal pain and those kinds of things. But that fluid will come back. It will always come back. Once it's happened, it will always come back. And then the anascara is that severe generalized edema, and we usually see that in end of life, where people start beginning to have that. Signs and symptoms, and this is very important to remember when you're looking at dehydrate or overhydration or excess fluid. How do we tell that somebody has too much fluid on board? I mean, what are things that you see when somebody has too much fluid? What do you think?
Really swollen feet.
Swollen feet, yep. Edema, perfect. What else, Emma?
Like leaky legs.
Absolutely.
Puffiness.
Okay. We also see engorged neck veins. So if somebody was laying on their bed and they turned their head, they would have these engorged veins in their neck. And that's just because there's so much fluid in the vascular system that those veins are engorged. And you'll see that in some people. So that's a lot of times, you'll see people who have congestive heart failure, and, the doctors will, turn their neck both ways. They're looking for those engorged neck veins. We also monitor weight. have people weigh themselves every day at the same time of the day. And we're monitoring how much fluid is on board just by monitoring their weight and having them keep a record of that. And typically we tell people, if you've gained more than 5 pounds within a week, you need to come in, because that means that we need to increase your Lasix, or they probably need a paracentesis or a thoracentesis at that time. The other thing is you got to think about is that when people have too much fluid on board, they have too much fluid in their vascular system, so we see it in their veins. But what happens is that when there's too much fluid for the heart to pump out, it begins to pool in the lungs. And you see people with shortness of breath and coughing and hacking and those kinds of things. So that's really your congestive heart failure, because that heart cannot pump all that fluid in their vascular system, and so it starts to pool back into the lungs. And so we see that dyspnea and the crackles and the frothy sputum, the cough and stuff that they have. So those are signs of overhydration. And so those are all signs that it didn't take any blood work. It didn't take any radiology. That was just signs and symptoms and doing a good head-to-toe assessment. And you can diagnose that kind of stuff. You can find that these are all head-to-toe assessment stuff. Looking for edema, looking for engorged neck veins, listening to lung sounds. Are they wet? Are they, are they short of breath? Is their oxygen going down? Weighing somebody. So that's all it took for you to diagnose somebody with overhydration. So things that we need to do, or how can we correct overhydration? Well, we need to put them on oxygen, because if they have too much fluid in, they're not going to be breathing very well, and so we'll probably need to supplement them with a little bit of oxygen. Then position changing them, putting their heads up so that they can breathe better, will make them feel better. And then we will go ahead and we'll put them on fluid restrictions and those kinds of things so that they're not having so much fluid on board. And then we're going to go ahead and put them on Lasix or a medicine like that to kind of help their kidneys excrete some of that fluid. And then monitoring intake and output, monitoring their weight very closely, all of those kinds of things. So those are some of the things that we do when we see people who have overhydration. And those are the signs and symptoms. Those are the things you pick up just from doing a head-to-toe assessment. But you got to clue into them, and you got to know what you're looking for when you talk about that. So those are some of the things that we talked about. So if we have overhydration, we can have dehydration. And causes of dehydration is like, people who have excess amounts of diarrhea, people who are on diuretics and they're doing diuresis too much, so they're peeing too much out. People who have fevers, and that's so important to remember, especially for little tiny kids. It doesn't take many times for them to have a fever to get dehydrated. So when they have a fever, their temperature goes up, and so they start using energy, and that energy is usually will start withdrawing all that fluid from them. So it doesn't take much for them to get dehydrated. So making sure that if somebody is having recurrent fevers, you got to have that in the back of your mind. Somebody who has a lot of diaphoresis and they're sweating a lot. So if you think about people who are working out and running, something I don't have to worry about that problem, but some people who work out have to worry about that, and they sweat too much. Or people who are like working outside and in the elements on very hot days and those kinds of things, they can get themselves dehydrated very, very quickly because they're diaphoretic and they're sweating that out. Those pores are big, and that fluid is getting lost through those pores. People who are vomiting a lot, very easily to get dehydrated about that. And the other thing that you don't think about probably very often is people who are hemorrhaging, people who are bleeding, will get dehydrated immensely. So little old ladies who fall down and break a hip, they can lose 2 pints of blood in that broken hip in a matter of an hour. So very careful that we think about those things, and we think about that hemorrhaging. It's just not that wound that's gaping and spitting out blood at you. It's those things happening on the inside as well. People who have renal disease and esophageal varices, they can bleed. So what they have is they have weakening of vessels in their esophagus and in their portal veins, and they'll start bleeding and oozing on the inside very, very quickly. So those people all become dehydrated because they don't have enough fluid in their body. So dehydration is when the output exceeds the intake. Things that we have to be concerned about is when they get dehydrated is hyponatremia and hypokalemia. So their sodium can be too low and their potassium can be too low. Signs and symptoms, things that people will complain about, is they have increased thirst. I'm peeing all the time. Their oral mucosa is very dry, so they're sucking on candies and those kinds of things to moisten up their oral mucosa. And older people get confused. When their sodium begins to drop, they have significant confusion. So making sure that we're monitoring for those kinds of things. So if people have so much dehydration that, hello? Hi, Tate. People who have so much dehydration and there's not enough fluids, like people who are hemorrhaging or people who are very, very sick and they get very, very dehydrated very, very quickly, these people can go into what we call hypovolemic shock. And that's when the body does not have enough vascular supply to pump the blood through the body. They will go into hypovolemic shock. That's why we can't, as nurses, as professionals, we have to be able to monitor this. We're the people who have our eyes on these patients, clients, and residents on a regular basis. This has to be us. We have to watch for these things. Signs and symptoms or things that we can do is watching their cap refill. So if you just take your finger and you push your finger down, you should it should turn white and then turn back to red very, very quickly, right? People who are dehydrated, that will not happen because they don't have enough vascular supply for that blood to feed the tip of the finger. So they have delayed capillary refill, so more than 3 seconds. They will have tenting of the skin. So if you take your hand and you pinch your skin will go right back down to where it was at, right? Now, people who are dehydrated, it won't. We call it tenting. And that's when the skin peaks up like an old-fashioned tent. And those peaks will be there because they're so dehydrated, the skin starts to stick together. That vascular system is not there to make it go back to normal. And then they have poor skin turgor, and that's, it's dry and it's cracked and those kinds of things. So those are all things that you observe, that you can see, that you can monitor. That's your head to toe assessment, looking for dry oral mucosa, looking for tenting, capillary refill, the skin turgor and those kinds of things. The other things we got to think about when we're looking at vital signs is that these people will have lost weight. They're not gaining weight, they're losing weight. So maybe yesterday they were 110 pounds and now today they're 108 pounds. That 2-pound weight loss for somebody at 110, that's a big deal. That's a big, big deal. Now, a 2-pound weight loss for somebody my size, not such a big deal. But those little people, those little fragile people, our little tiny kids, that's a huge deal. And so we need to monitor that weight very closely. The other thing is that we're watching for their pulse. People who are dehydrated, their pulse goes up. And the reasoning behind that is that, remember, there's not enough vascular supply. There's not enough blood in that system. So the heart has to pump harder to get the blood to the brain, to get the blood to the toes. And so because the heart is beating harder, it's beating faster. So they get tachycardic. And that's a sign of dehydration. We will typically see blood pressure start to go down. And the reasoning is that vascular supply is not there. So the systolic pressure and the diastolic pressure are starting to trend downwards. And you'll see those kinds of things. We'll also see people in late signs of dehydration where they will have tachypnea, where they're breathing too fast. Because again, that vascular supply, that blood isn't there. And if the blood isn't there, the oxygen's not there to the lungs. And so they have to start breathing faster to make sure that they're getting enough oxygenation. So those are signs of dehydration when we're monitoring blood, when we're monitoring vital signs. Loss of weight, tachycardia, low blood pressure, tachypnea. Those kinds of things are things that we have to monitor for. And those are all signs of dehydration. Okay, questions with that? There is a table in your book. So if you went to, it is the Med Surgical book. There was a section on fluid and electrolytes. I think it's page 953. I'm going to grab my book to make sure I'm not lying to you.
Emma,
Yeah.
what? I don't have the PowerPoint sheet for this lecture. Do you?
Or fluid and whatever.
I can't find it. Did she hand it to us on?
No. She handed us 2 of them, and she handed one of them was the professional communication,
Right.
and the other one was it was nutritional. IHS dietitian shadowing preparation.
Oh, okay. Because I didn't have a PowerPoint sheet for this, so I didn't.
I emailed this one out. For this one?
Yeah.
I don't have a printer, so I'm sure it's probably in my email.
Okay.
I never got an email.
I emailed this one out yesterday.
You emailed a couple things, right?
Yeah, I emailed.
Is it pigment or
fluid and electrolytes. Did you get it, Tate?
Yeah.
Okay.
Yeah, I have them. No.
So Kobe, you're not getting my emails, huh? They're
right.
not.
Yeah.
Can one
I
of
don't
you guys
have
try
any
to forward that to him?
He has you tagged in it, buddy. As Keisha4@msn.com.
Yeah, CASIA4@msn.com.
You're on there. You're in the tag.
What the heck?
I guess I can forward it, but I don't know. I think that since will it tag everybody else again too?
Kobe, will you be in our area? Will you be coming to Wagner? Anybody coming to Wagner?
We'll be in class tomorrow. We can print them tomorrow.
Okay. Okay. Just because it's so
Okay.
important that you have this printout, and when we get to acid base, we'll go over that, and I'll show you why it's going to be so important. Okay.
So we don't need one on pain, right?
Pain is next week. That was my fault.
That's okay.
Pain.
So I'm on the right page with you then.
Yeah. Yep. Pain is next week.
Okay.
Yep. Fluid and electrolytes
okay
is this week, and pain is next week.
Okay. I'm okay then, because I was wondering. I thought yeah.
If you go to page 953 in the Perry Potter book, there is a care plan in there on dehydration. And it kind of talks about all the things that we talked about, how heart rate, will go up, blood pressure will go down. So there's a care plan in there. So kind of read through that. I think it'll just kind of help you put this knowledge into a picture so that you can see it on a patient to begin to understand what it looks like. Because otherwise I think it's hard to understand, well, the pulse is up and the blood pressure is down and those kinds of things. But when you get to see it with a patient in like a care plan, I think it kind of helps begin to kind of click that in. Okay. Okay. So water is 45 to 77% of our body. That's of our fluid is all water. And so that's why it's so important that people are drinking plenty of water, because we have to replace what we're losing by sweat and urine and just normal condensation and those kinds of things. So people need to make sure that they're drinking plenty of water. Water helps with the transportation of waste and nutrients in our body. It lubricates, so it's lubricating all those cells and the organs and all of those kinds of things. And it regulates blood pressure. It regulates temperature, osmotic pressure, and the body's pH. Okay, so just making sure that water is a vital portion of what people are drinking. Okay. So the things we've talked about fluid excess, we've talked about dehydration and knowing what they look like. And so knowing what those signs and symptoms are, things that cause them, and what we're going to monitor for. Okay, so our eyes, nose, and our weights, and monitoring vital signs and all of those kinds of things. So making sure that we're watching those kinds of things. So from that, we're going to go into electrolytes. Okay. Now there are tons of electrolytes. We've talked about, how sodium is on the outside, potassium's on the inside, magnesium's on this inside, phosphorus is intracellular, all of those kinds of things. So what I think is important to remember from intracellular to extracellular, and this is taking you all the way back to pathophysiology, is that's that transfer of that potassium sodium pump. So if the potassium goes out, sodium has to go in. We have to exchange those anions and cations. And so just that sodium potassium pump. And if you think about that, we learned that back in pathophysiology. Don't remember it, I would go back and just reread that, okay? Just so that things make more sense to you. So I have intracellular versus extracellular. All I really want you to know about that is how there's that transfer of cations to anions when there's a transfer of osmosis or diffusion in fluids. So intracellular electrolytes, potassium. Now I have, if you look on those two slides, I have their values, what their normal values are, okay? So potassium is 3.5 to 5. Magnesium is 1.5 to 1.9. Sodium is an extracellular, and that's 135 to 145. And bicarb is 22 to 26. Okay, I'm not expecting you to memorize all of them, but there is some that you have to know. You should know what normal potassium is. You should know what normal sodium levels are. You have to know what normal bicarbonate is, because when we get to acid base, you need to know those values. Okay, don't have to know all of them, but those are the ones you have to know. Okay, and in your book, on table 42-5.
Fluid therapy.
Electrolyte imbalances. In Perry Potter,
Yeah.
page 942.
942.
So 940 to 942 in Perry Potter, it talks about the electrolyte imbalances. So important that we know what happens with them, okay? If there's an electrolyte imbalance, so if potassium is too high, potassium is too low. So we know that when potassium is too low, people have muscle cramping and pains, because potassium is important in muscle structure and muscle toneness. So if it's too low, we see muscle weakness and cramping and pain. If it's too high, we see muscle rigidity, and we'll see changes in people's EKG status. People can go into cardiac failure when their potassium is too high. They get what we call peak T waves, and those peak T waves can put people into cardiac arrest. We see electrolyte imbalances most often in people in the dialysis world, and we'll see potassiums. The highest potassium I think I've seen was a 12, and that person did pass away. So it can happen. We do see potassium changes. Not very many people are not, over the age of 70 are not on some type of diuretic. So if people are on Lasix, people are on spironolactone, we can have potassium changes because we're increasing the body's excretion of urine and fluids. And so if we're increasing the excretion, we're increasing the potassium that can be put out, and we can put people into hypokalemia. If they're on spironolactone, because spironolactone is a potassium-sparing diuretic, we can put people into hyperkalemia. So just very important that we're monitoring these values when people are on those kinds of medications, and that electrolyte imbalances can cause some funky looking things. So you got to know what those potassium, what those are. Important to know what potassium looks like. Important to know what sodium looks like. Important to know what calcium looks like. With hypocalcemia, we see Trousseau's and you'll see checks-off signs. And so a Trousseau sign is when you are taking somebody's blood pressure and their fingers will start to twitch. That's called Trousseau sign, and that means that they're low in calcium. What?
It's a Trousseau sign.
Trousseau. Yep. It's got to be a picture in your book. Let me find it. Are you kidding me? There's no picture in here. All right, hang on. I know there's one in the med surg book. Let me find it.
What slide are we on?
We're just talking about electrolyte imbalances, intracellular and extracellular. So, do you have your med surg book?
I don't have it here, no. Yeah.
On
How do you spell it, Kobe?
Trousseau's is Trousseau.
What page is that on?
Page 83, Kobe.
83. Oh, wow.
Are you there?
Yeah.
So this is for people who have hypocalcemia. And so you'll notice when you do a blood pressure, their fingers will start to twitch, and that's called Trousseau's. I just remember T with twitching. Checks-off. Checks-off is CHVOSTEK. And checks-offs is when you rub their cheek will start to twitch. So I just remember cheek and checks-offs, Trousseau's, and twitching. That's how I remember them. So that's hypocalcemia. Important to know that what hypocalcemia, what you're going to monitor for and what you're going to look at. So know what that one is. And if you go through those tables 42-5, and it'll talk about hypo, hyper, and just knowing what those signs and symptoms are of that. Okay. Fluid is transported through the body through passive or active transport. Passive transport means that it uses no energy whatsoever. So diffusion is just from a higher level of concentration to a lower level of concentration. So those molecules will just follow the flow. So I think about diffusion reminding me of like how water flows downstream, right? Everything just flows downstream and everything just goes the way it's supposed to go. That's diffusion, just from higher to lower. And that's just like water flowing down the stream. Osmosis, though, is going from a lower level to a higher level of concentration. And so I think about salmon when they're swimming upstream, right? So that's osmosis, and is when they're fighting that current, and they're going from an area of lower level to higher level. So if you think about those salmon and how they swim upstream against the current, that's osmosis. And filtration is just higher pressure to lower pressure. So it's just, it's just flowing down the stream the same way. None of these take any energy as well. So water will move in and out of the cells. It will transfer potassium to sodium. That's how it happens. And it happens through diffusion, osmosis, or filtration. Active transport is when it uses energy. So if you think about fluid going from intracellular, and when we're going into the cellular, it uses energy. Remember, we talked about mitochondria when we were in pathophysiology, and how mitochondria is the energy source for the cells. And so that's what we're using, is that active transportation. And so if you have big molecules and you have to bring them into the cell, that mitochondria needs to use that energy to transport that molecule into the cell. That's active transport. I don't think this is like life or death, so don't spend a lot of time studying this stuff, okay? Don't spend a lot of time. I want you to understand the concept. So, things that we've talked about thus far. We've talked about overhydration and dehydration, what they are, what symptoms they are, nursing things that we're going to do to monitor those kinds of things, and then things that cause them. So knowing a little bit about those kinds of things. We've talked about it's important to know about electrolyte imbalances, hyper to hypo of sodium, calcium, magnesium, and calcium. Okay, those are the 4 electrolytes you've got to know. Okay, and you need to know what their normal values look like. Okay, you should be able, if somebody's potassium level comes back and it's 5.5, you should be able to know that they're hyperkalemic. If their potassium comes back at 2.9, you should be able to know they're hypokalemic, versus hyponatremia and hypernatremia. Those are things that you'll be asked on tests. You need to know those values. Those 4. So sodium,
And that was what?
Sodium,
Okay.
potassium, calcium, and magnesium. Okay? And then we're going to talk about 2 others you have to know, the bicarbonate and CO2 levels. Okay? And you have to know that for acid base and understanding acid base. So I really want to spend the rest of this time talking about acid base, because acid base is what people struggle with the most. Okay, just a second, I'm going to turn on my light. So if you remember when we started tonight talking about how the body, how our fluids and our electrolytes always want to maintain homeostasis. Okay, homeostasis is a pH of where all of our cells are at a pH of 7.35 to 7.45. If our cells are within that pH, they are a bunch of happy campers. When they're not, things go awry. And that's when people go into what we call acidosis or alkalosis. Okay? And that's so important for us to be able to know this. It's a very simple math game. You just got to use it and got to practice it to become more comfortable with it. So our body maintains that pH of 7.35 to 7.45. That is normal. And so if it is lower than 7.35, is that an acid or a base?
Base.
If it's lower,
Acid.
yep. If it's below 7.35, it's an acid. If it's above 7.45, that's a base for alkalosis. Okay. So it's kind of, I think Kobe, I agree with you. I always like to think the acid should be higher or not, but it's the opposite of what you think it is. The acid is the lower number, the base is the higher number. Okay?
Okay.
And then we're also looking at CO2, and that's how much carbon dioxide is in the lungs. Okay? What that PaCO2 level is. And that should be between 35 and 45. And then the bicarbonate, that is in your stomach, the bicarb, and that number should be 22 to 26. So when you print out these slides, or when you have these slides up, I have a nice little box that says acid-base balances. These are the normals, okay?
That's from the Perry Potter book.
That's in my lecture notes.
Oh, gotcha.
On my slides. It'll have acid-base balances, and it'll have what the normal pH, what the normal PaCO2 is, and the normal HCO3. Now, to be able to diagnose somebody with acid base, or if they're alkalosis or acidosis, we have to do an arterial venous puncture. So we need arterial gases. So to get an arterial gas, you don't draw blood from a vein. When we start an IV, we start it in the vein, right? When we draw blood, we draw it from a vein. That's what we do. But we can't. When we're looking at somebody who is in acidosis or alkalosis, we need that arterial line. So if you feel on your radial pulse, and you can feel that that's your radial artery that you're feeling, that's where you draw for blood gases, is you draw from that artery. So remember, arteries have pressure behind them, and because it's pumping directly from the heart, so they have lots of pressure. So once you tap into that artery, you have to apply a lot of pressure to that, or otherwise that blood will keep spurting out at you. Okay, so make sure you apply plenty of pressure to that. But when we're diagnosing acidosis or alkalosis, we have to get it from the arterial bloodline, and that's from that radial pulse. You can get it from, from any arterial line. You can get it from an art line. You can get it, so any artery you can pull it from. We just typically pull it from the radial artery. So we're looking at, that will give us what our pH is. It will give us what the body's CO2 level is, and it will give us what the body's bicarb is. Once we get that arterial number back, those blood gases back, it will tell us that. From that number, then we can begin to decipher whether a patient is in acidosis or whether a patient is in alkalosis. So when you are diagnosing this, you will have a little area that says acid base, and it's on page, I print mine out in 7s. So slide 21, and it will have metabolic acidosis, respiratory acidosis, metabolic alkalosis, or respiratory alkalosis. And so it'll tell you that for metabolic acidosis, they have a decreased pH, and they have a decreased HCO3. Respiratory acidosis has a decreased pH. Okay, remember, so anything that the first thing you can do is you can always rule out whether they're in acidosis or alkalosis by looking at the pH. So if I get a pH and that pH comes back at 7.6, are they alkalosis or acidotic?
Alkalosis.
Alkalosis. So you've cut it in half now, right? Because either they have to be respiratory alkalosis or acidosis, or they have to be metabolic acidosis or alkalosis. So just by looking at the pH, you've limited your answer by 50%. Just by saying acidosis or alkalosis, you've eliminated it to half. Okay, so the first thing you do is look at that pH level, and the pH, if we said if it's 7.6, they are in alkalosis. If it was 7.3, what are they in?
Acidosis.
What if they are 7.52?
Alkalosis?
What if they are 7.31?
Acidosis?
Okay. So being able to determine what acidosis and alkalosis looks like is very, very important, okay? Let me, do you guys have your, you don't have your med surge book?
I can probably get mine. It's in the car.
Why don't you go grab it? Why don't you go grab it? And we're just going to practice this, okay?
Okay.
What page do you want us on?
You have your med surge book, right? 86.
Yep. Okay.
Okay.
Page 86, Emma. Tate, do you have your book?
I don't have my book with me.
Okay, but you have my PowerPoint, right?
Yeah.
Go to slide 21.
Okay.
Okay, so for Emma and Kobe who have your med surge books, on page 86 you see table 6.4, right?
Yep.
And it has your pH, your PCO2, and your HCO2 levels, right? So that's the body's pH, your CO2 level, and then the HCO3 is the bicarb level, okay? So you can tell if somebody's in respiratory acidosis because their pH will be low, right? Because we said acidosis is low. And their PCO2 will be elevated. That is the definition of respiratory acidosis, okay? So somebody comes into the hospital and they have chronic obstructive pulmonary disease. So that means that they're not breathing very well. They can't exchange oxygen for carbon dioxide very well at all anymore, okay? And so they come in and they look awful. Their SATs are at 76%. They're breathing like 40 breaths per minute. Their heart rate is 140. They look awful. They look toxic, okay? So you get an arterial line, an arterial gas line, and in that you find out that their pH is 7.29. Are they acidotic or alkalotic?
Acidotic.
Okay. Then you find out that their PCO2 level is at 54. Are they in respiratory or metabolic? With an elevated, okay, respiratory, and we said they were in acidosis, right? Okay.
Right.
Somebody who is in respiratory acidosis is most likely somebody who has chronic lung problems. So they have CA of their lungs, so they have metastatic cancer of their lungs. They have COPD. They have chronic bronchitis. They have CHF. Those kinds of things. So they're not exchanging air very well, and so all of that air is building up in those lungs, and so they become respiratory acidotic. Okay, so for respiratory acidosis, if you look at that table, and if you look at that slide 21, Tate, For respiratory acidosis, they have a decreased pH and an increased PCO2. That is the definition of respiratory acidosis. And respiratory acidosis is typically somebody who has chronic lung disease. Those are the people you're going to find that have that, okay? Now, let's say that you have somebody who comes in, and have you ever been to a ball game and a basketball game, and they're playing hard and somebody begins to hyperventilate? What does hyperventilation look like?
You can't catch your breath.
Yep, they're like so what is happening is they are blowing off all that CO2 because of that hyperventilation of theirs, okay? So you draw an arterial line on them and their pH is 7.52. Are they in alkalosis or acidosis?
Alkalosis.
Alkalosis, absolutely. Then their PCO2 is at 24. Which
Alkalosis.
definition? Okay, but is it respiratory or metabolic?
Respiratory.
Respiratory. So somebody who's hyperventilating or blowing off too much CO2 is going to be in respiratory alkalosis. Okay? That defines respiratory acidosis, respiratory alkalosis. Okay? So what you need to be able to do, and you got to just use this table. And when you get my worksheet that I sent out, I have about 10 practice things at the very bottom of my worksheet for you guys to work through metabolic, respiratory acidosis, alkalosis, okay? And I just want you to practice working through them. So if you use that table in your book, 6-4, or if you use the chart in my notes, and that's on slide 21, you will be able to begin to decipher whether they meet respiratory alkalosis or respiratory acidosis, okay? So the thing about it is, if you think about it just like this, look at the pH. Is it high or low? That will define whether they're acidotic or alkalotic, right? So
Right.
now all you have to do is decide whether it's respiratory or not. So if it's respiratory alkalosis or respiratory acidosis, I don't care. If it's respiratory, it's the PCO2, right? Because it's the oxygenation or the carbon dioxide. So all you really have to do is look at the PCO2 and the bicarb. Is the bicarb normal? If the bicarb is between 20 and 26, you know it's got to be respiratory, right? Because if you go down the chart and you look at metabolic acidosis, it's normal for the PCO2, right? And if you look at respiratory acidosis and alkalosis, it's normal for bicarb, right?
Right.
Very simple, right? It looks like this big, extreme, scary thing. But all you got to do is look at the pH and decide acidosis or alkalosis. Then you got to look at the bicarb and the CO2. If the bicarb is normal, you know it's got to be respiratory, right? If the CO2 is normal, you know it's got to be metabolic. That's pretty simple, right? So don't overthink it. That's all you got to be able to do is decide whether the pH is normal, too high or too low. And then you have to decide whether the HCO2 or the HCO3 or the CO2 is normal or abnormal. Okay? So if it's the bicarb, it's got to be metabolic. If it's the CO2, it's got to be respiratory. That's all that's to it, okay? Do not overthink it. Because that's what typically happens is everybody tries to overthink it. And if you can do those two things, you will get it right every time. Make it simple. Is it acidotic or alkalotic? Is the bicarb or the CO2, which one is messed up? Whatever one is messed up, it's going to be either respiratory or it's going to be metabolic. It doesn't sound that difficult, right?
Right.
Right.
Okay. So write down exactly how I want you to do it. Because if you follow that every time, this is going to be so simple. But when you try to start thinking through things and making it more difficult than it is, you're going to get all scatterbrained and you're not going to be able to figure them out, okay? So is it acidosis or alkalosis? And then look at the bicarb or the CO2. And whichever range is out of normal, it's got to be respiratory or alkalosis, or respiratory or metabolic, okay? So along with the normal values for potassium, sodium, calcium, and magnesium, you need to know pH, bicarb, and CO2. Okay? 7 lab values. And you'll be fine. Okay? Now, I have that put down on my study guide as well, that those are the ones you have to know. Okay? So just do that. When you get to your study guide, when you print that off and you have that, just go to those. I have 10 of them listed, those practice ones, and then just start fitting them in. Go to the table and just practice figuring out whether it's respiratory or metabolic. And then it will become very easy for you. Okay? Do not overthink it. Okay? So somebody who has the number one cause of metabolic acidosis is what? Do you know?
Loss of acid.
What causes it?
Stomach. Using antacids or baking soda. Loss of acid and also lead to metabolic alkalosis.
So
Have increased.
So that's alkalosis, right?
Yeah.
Acidosis most typically is diabetic ketoacidosis. And that's the number one cause of metabolic acidosis. So those are the people, those are the diabetics who are truly uncontrolled or they are newly diagnosed diabetic and they come in with sugars of 900s, thousands, 1200. Those people are in diabetic ketoacidosis. And so you diagnose the diabetic ketoacidosis or the metabolic acidosis by looking at the pH. And is it too high or too low?
It would be too low.
Okay. And what about the bicarb?
The bicarb would be too low.
Too low. Okay. So it's metabolic acidosis, and that's diabetic ketoacidosis. The most common cause of metabolic alkalosis is when people are using GI and stool softeners. So you have those people who always have acid reflux, and they're popping Tums, and they're popping Pepto-Bismol, and they're pepting all of those kinds of things. That can drive them into metabolic alkalosis because those are all alkalizing agents. We're trying to reduce the acid, and they overdo it, and they get themselves into that. We also see metabolic alkalosis in girls who are bulimic or anorexic because they'll overdo laxatives trying to lose weight, and it reduces their it reduces their alkalosis. So these girls will take high doses of X-Lax, will take high doses of mag citrate, those kinds of things to make themselves go to the bathroom and all of those kinds of things. And so those two caveats are the most common cause of alkalosis. Most common cause of metabolic acidosis is your diabetic ketoacidosis, okay? And then respiratory acidosis are those people who have chronic lung disease And acidosis are those people who are hyperventilating because they're blowing off too much CO2, and it's causing them to go into alkalosis. Okay? All right. So that is a lot of information, okay? So the key to this, honestly, the key to this is do not overthink it, okay? Go through and use those practice regimens on there. In the back of the book, of your med surge book, there is a couple of practice acidosis, alkalosis questions. It's the same in the Perry Potter. And then when we get together on Sunday, if you guys still need more, want to go over them again, I will be happy to go over that with you again on Sunday as well. Okay.
Next Sunday we say at
8. Okay.
Sunday at 8.
I do. Have you guys gone over at all any thing with Bree on calculating fluids?
Mm-mm.
You haven't done any.
That's coming up.
I cannot remember if I put that. I don't think I put that question on the test. I don't think I put it on there. I don't think I did. And then, so the different fluids and different meds that we use to correct acidosis or alkalosis would be, we use bicarb for people who are in metabolic acidosis. We'll give them bicarb to kind of try to bring that acid level number up by adding more of the bicarb on board to try to bring them back to normal. If somebody is in metabolic alkalosis, we'll give them a little bit of acid to try to bring that back up. So calcium gluconate and those kinds of things are more of an acidic nature, trying to balance that out a little bit. And then the same goes for, respiratory acidosis or alkalosis. We would use neutralizing agents. Things I want you to take away for IV fluids that we use, and Bree will go over this with you guys more in depth because she's teaching the pharmacology section on it. But I want to throw this just in there with you guys when we're talking about fluids and stuff. There's 3 different kinds of IV fluids, and one is hypertonic fluids, one is isotonic fluids, and hypotonic fluids. Hypertonic fluids are fluids, what they will do is they will shift fluid from the cells back into the vascular system. So it's pulling that fluid from the cells back into the vascular system. Reasons we would use hypertonic fluids is if you think somebody who, if you think of somebody who's been in a bad crash and they have lots of cerebral edema or swelling on the brain, I want to give them a hypertonic fluid because I want to try to pull that swelling and all that fluid from the trauma of their brain back into the vascular system, because I don't want to do a burr hole in the emergency room out in Timbuktu, right? I'm not going to drill a hole in their skull to try to bring that back down to normal. So I would use hypertonic fluids to pull that fluid that's in the interstitial back into the vascular system. Isotonic fluids is the ones that we use most often. And isotonic fluids is that fluid will stay within that vascular system. We're not trying to pull fluid from the interstitial fluid back into the vascular system. We're not trying to put fluid back into the interstitial fluid. We just want it to stay in the vascular system. So our little people who are hemorrhaging, right? We talked about hemorrhaging being, or vomiting or diarrhea, those kinds of things causing dehydration. We'll use isotonic fluids just to give them fluids back into that vascular. So like for little kids who come in and they're dehydrated, they'll be tachy at 140, 160s. Their blood pressure will be a little bit low. Their skin will be a little bit funky, tinting. Those cap refill is probably pretty bad. And we'll give those kids 100 to 200 cc's of fluid, of isotonic fluid. So we're just putting fluid back in that vascular system. And within a half hour, they'll pop out of it and they're talking to you and they're playful and life is good and you never knew that things were so rough for them. So just giving that back to them, we're just rehydrating them a little bit with that. And then hypotonic is when we use hypotonic when we're trying to fix like acidosis and alkalosis. So we're trying to shift that fluid from back into the cells, into the interstitial fluids. And so sometimes we'll use some hypotonic fluid. I'm not asking you guys to know this inside and out. I just want you to understand the difference between them, those three different kinds of fluids. And Bree will talk more about them in depth. I'm not going to go over any math and motion stuff if Bree hasn't started any of that. And then we also, for people who have those electrolyte imbalances, whether it be magnesium, potassium, sodium, whatever the case may be, we can give them supplements. So if they're hypokalemic or their potassium is too low, we'll give them potassium supplements, 10, 20 milliequivalents daily to kind of beef up that potassium level. If people have low calcium, we can give them Citracal or calcium 600, those kinds of things to bring that calcium level back up to normal. There's magnesium supplements, so Magox, those kinds of things, Slow Mag, those kinds of things to bring it up. We see that a lot in renal patients. They'll have low magnesium levels. We also see it in pregnancy. Where those magnesium levels will kind of change and get a little funky. So we may need to supplement during those periods of time. And then people who have low sodium, we can give them slow salt, but typically people who are hyponatremic, all we do is put them on a fluid restriction. And that fluid restriction will correct that sodium balance for them. So you can give them a sodium supplement, but typically we just put them on a fluid restriction, and then they'll be back to normal with that. Okay. Have you guys ever heard of water intoxication?
Yeah, like I've heard of nurses talking about how they worked in like the psych ward, and like these patients, they'll drink like insane amount of water and it'll get them like they're drunk.
Right, and it's because their sodium is dropped so low. Because of the water intoxication, we've dropped their sodium. Their sodium has gone from like the 135, they'll drop it all the way down to 116 and 110s. Did you guys watch, anybody watch Grey's Anatomy?
Yeah.
Mm-hmm.
Okay, do you remember that one crazy guy that was drinking water out of the toilet?
Yeah.
Do you remember that episode? That's what he had. He had water intoxication. And so he learned to function with his sodium being so low. So when the sodium was getting back up to normal, he would start drinking to bring his sodium back down low. And he went into cerebral edema because of it. And that guy ended up dying. But that's what he had, was water intoxication. So we can make people crazy. We can intoxicate people by having them have too much water on board because we're dropping their sodium down into low levels. Typically, when the sodium level gets down into below the 120s, they will start seizing. And they'll have so much cerebral edema, so much fluid on their brain that they'll start seizing. So if you want to go back, just for fun, since we're talking about it, and rewatch that episode, you'll hear them. What they hung, the fluids they hung, were the hypertonic fluids, the sodium, the 4%, the 5% sodiums, trying to pull that fluid off the brain, and bring it back into the vascular system. So that's what they were doing. So that's how the pieces of the puzzle all work together. So when people get water intoxication, their sodium drops, they can get cerebral edema and start seizing on it. And so for those people, in that episode, they were hanging hypertonic fluids, 3%, 4%, 5% normal saline. Typically, the isotonic saline we hang is 0.9%. So to pull fluid from the interstitial tissue into the vascular system, we will hang 6 to 7 times normal of the saline to get that process done for us. Okay, so that's kind of fluids and electrolytes. So just making sure that you go back and you're looking at the dehydration and overhydration, what those signs and symptoms look like, what you're going to monitor, so what vital signs will look like, monitoring intake and output and weight and all of those kinds of things. Then when we start looking at fluid or electrolyte imbalances that can happen because of dehydration and overhydration, then we can start to get fluid or electrolyte imbalances and knowing what hyper versus hypo look like, and then how we treat them, and what those normal values should look like. And then the last thing that we talked about was the acid-base levels. And that's looking at the pH, because remember, our body wants to maintain homeostasis, and it wants that pH to be between 7.35 and 7.45. If it's not, we go into acidosis or alkalosis. And the acidosis or alkalosis is either respiratory or metabolic. And then knowing the causes for the metabolic and for the acidosis and alkalosis, both on the respiratory and then on the metabolic side of things, okay? Now, those review questions that I sent out, they kind of review all of that kind of stuff. And then I will be on vacation this weekend, but you can email me. I will check my email. I will check my my texting. So if you have any questions and you need to text me something, please go ahead and do that. And then we'll get together again on Sunday night at 8 o'clock and we'll do any review that you guys want to do for the test, okay? I will send out my test review plan for you guys tonight, so you should have that tonight. Kobe, if you do not have it, make sure they print it off for you tomorrow at class so that you have that for this weekend to study, okay?
Okay, sounds good.
Okay, so I'll send all of that out. Make sure that you've got everything printed out. And next week will be pain management. Not this week, next week. Okay? All right. Any other questions for me? I know this was a lot of information, but just go back and read through. So there's a chapter in the Med-Surg book. Read that one. There's also a chapter in Perry Potter. Read that one. And do not forget to look at your ATI book, because a lot of those questions come from the ATI. So make sure that you review that ATI book as well. Okay? All right. I will go ahead and text or email that out to you, that study guide. And if you have questions or anything comes up, please get a hold of me and let me know.
Okay.
Awesome. You guys have a great night. Have a good week. We'll see you Sunday.
Thanks,
None. Kobe.